Zoll LifeVest is a proud sponsor of CardioNerds. Zoll has continuously improved LifeVest for over 20 years, leading to a median real-world wear time of 23.4 hours per day and an AI-enhanced algorithm that delivers zero median false alarms at 90 days. The newest LifeVest garment is lightweight, breathable, and preferred by patients for its comfort. Learn more at lifevestinnovation.com.
Hey CardioNerds, Dan Ambinder here. Thanks so much for joining us for another amazing episode. Today we'll be diving into the SUMMIT trial with the one and only Dr. Milton Packer, a true pioneer in heart failure research. The SUMMIT trial explores the impact of tirzepatide on patients with HFpEF and obesity, offering exciting insights into treatment strategies and outcomes for patients with HFpEF. This episode was planned in collaboration with the American College of Cardiology section of the Prevention of Cardiovascular Disease with mentorship from section chair Dr. Eugenia Gianos. And with that, let's dive right in.
Hey CardioNerds, this is Jenna Skoronsky, chair for the CardioNerds Heart Failure Council and currently an advanced heart failure and transplant cardiology fellow at Vanderbilt. I'm here with CardioNerd Myrna Hussain, currently a MedStar Cardiology Chief Fellow and future advanced heart failure and transplant cardiology fellow at Duke. We're joined by the one and only expert faculty, Dr. Milton Packer. Dr. Packer is a pioneer in the field of heart failure and clinical investigation. He has authored over 500 peer-reviewed publications and has been the principal investigator for 20 international trials of interventions in heart failure. He is a founding member and past president of the Heart Failure Society of America, currently serves as a distinguished scholar in cardiovascular science at Baylor University Medical Center in Dallas, Texas, and a visiting professor at Imperial College in London. We'll be discussing the SUMMIT trial with him, a trial that he was a principal investigator for. This trial assessed the impact of tirzepatide, a dual-action GLP-1 and GIP agonist, on patients with both HFpEF and obesity. Let's get started with the case.
Thanks, Jenna. We have a 64-year-old woman with past medical history of hypertension, type 2 diabetes, CKD stage 3A, and obesity with a BMI of 38 kilograms per meter squared. She was admitted 3 months ago with worsening shortness of breath with minimal activity and was found to be volume overloaded on physical exam. Her echocardiogram then showed mild concentric left ventricular hypertrophy and a left ventricular ejection fraction of 55 to 60%. As well as a grade 2 diastolic dysfunction, normal RV size and function, dilated left atrium, and no significant valvular disease. She was diagnosed with heart failure with preserved ejection fraction and received IV diuretics with improvement in her symptoms. She was discharged on daily furosemide, spironolactone, losartan, amlodipine, metformin, and atorvastatin. She presents to cardiology clinic for post-hospitalization follow-up. She shares that while her shortness of breath has improved compared to before the hospitalization, it still limits her from walking more than 1 block at a fast pace or going up 2 flights of stairs. Repeat lab workup showed stable creatinine and electrolytes and a normal NT-proBNP. Repeat limited echocardiogram shows improvement to grade 1 diastolic dysfunction but persistently enlarged left atrium.
Dr. Packer, before the SUMMIT trial, what did we know about the management of this patient? I've heard a lot of discussion surrounding CKM or cardio kidney metabolic syndrome. Is this the type of patient you would put in that category? And if it is, how does that change the way that you think about her?
Well, this is a very common disorder, but let me start by making a few, I think, seminal points. First is the overlap between obesity and HFpEF is enormous. It's estimated that about 60-70% of patients with HFpEF have a BMI greater than 30, but almost all of them have a increased waist to height ratio, which means they have visceral adiposity. And when we talk about HFpEF and we talk about obesity, we're talking about the same patient population. Now, some of them may have chronic kidney disease, but that's not the driver of what is happening. And I personally don't like to use the word cardiometabolic kidney disorder because I don't know what it means. So I do like to use the term adiposity-related HFpEF. And that essentially is almost everyone with a waist to height ratio greater than 0.5 and heart failure symptoms and a ejection fraction greater than 50%. So many of them may have chronic kidney disease, but not all. Many of them have normal levels of natriuretic peptides, as this patient did. And the reason is that natriuretic peptides are not typically markedly elevated in HFpEF anyway, but they are particularly not elevated and typically are in the normal range in patients who have obesity because an expanded adipose tissue mass suppresses natriuretic peptides. So this is a pretty common patient in the population. It's a patient who I would diagnose with either adiposity or obesity-related HFpEF. And really, we can talk about why those two disorders, obesity and HFpEF, overlap so much.
Thank you so much. That's really helpful. Just to get into the trial a little bit and summarize for our listeners, the SUMMIT trial is a randomized, multi-center, double-blinded phase 3 trial that evaluates the following question. In patients 40 or older with HFpEF, as defined by LVEF greater than 50% and NYHA class 2 to 4 symptoms, in addition to a BMI greater than or equal to 30, does maximally tolerated tirzepatide, as compared to placebo, effectively and safely delay time to cardiovascular death or worsening heart failure event? And also, what impact does it have on the Kansas City Cardiomyopathy Clinical Summary Score at 52 weeks of therapy? So, Dr. Packer, when I read this trial, I was really interested in the pivot on endpoints that occurred when the publishing of STEP-HFpEF in August of 2023 came out. My understanding is that trial transitioned from initial hierarchical primary endpoints into two separate, distinct primary endpoints. Since you are the trial PI, we'd love to hear a little bit about what went into that transition. And for those of us who don't live and breathe clinical trial design like you do, how common of an occurrence is it that you'll change the endpoints kind of mid-trial?
You've asked a lot of questions, and they're all really fascinating. First of all, the SUMMIT trial from the very beginning was designed as an events trial. We actually had cardiovascular death and, in fact, all-cause mortality plus worsening heart failure events, heart failure hospitalizations, or urgent care visits requiring IV therapy as the main components of a hierarchical composite. We expected about a 20 to 30% reduction in the risk of those events with tirzepatide compared with placebo. And the trial proceeded with those assumptions, and the expectation was that with the number of patients we had and the duration of follow-up, we might not see enough events to look at the cardiovascular death and heart failure hospitalizations alone. So we combined them with changes in KCCQ scores and 6-minute walk in a planned hierarchical analysis. And the trial proceeded that way. What was so interesting was the fact that the trial recruitment allowed us to take patients and follow them for long periods of time. It took time for the recruitment targets to be reached, which meant that patients were being followed on double-blind therapy for longer than had been originally anticipated. But the most important event was the announcement of the results of the STEP-HFpEF trial at the European Society of Cardiology meetings in August of 2023. And I remember sitting on the floor of the main auditorium when that trial was being presented, and the trial reported favorable effects on KCCQ. It was a trial that was truncated at 52 weeks. Semaglutide improved KCCQ, and it looked good. But the most impressive was an exploratory analysis, which showed that after 52 weeks of therapies, the patients in the semaglutide group had one worsening heart failure event. The patients in the placebo group had 12. I looked at this and I said, well, it's possible that that's due to the play of chance, but it's really unlikely, which meant that we could actually expect that incretin signaling could have a greater effect on worsening heart failure events than we had originally planned for. We had originally planned for a 20 to 30% reduction, and now we thought, well, could we see a 40% reduction? Could we see a 50% reduction? Well, if we could see a 40 or 50% reduction, then the SUMMIT trial would be able to evaluate worsening heart failure events as a standalone endpoint. We wouldn't have to have a composite, a hierarchical composite that we originally planned. So entirely related to data external to the trial without any knowledge of what was going on in the trial or the event rates, we took the original hierarchical composite and split it into worsening heart failure events and KCCQ. And that was what we had originally wanted to do. We originally had designed this as an event trial. It was initially thought that we would get a 20 to 30% reduction in risk. And now we thought, well, maybe we could get a 40 to 50% reduction in risk. And if we could do that, then we wouldn't need a hierarchical composite, and we could look at cardiovascular death and worsening heart failure events as the primary endpoint.
Wow, that's fascinating. Thanks for walking us through that, Dr. Packer. Well, let's then discuss the results of the SUMMIT trial. The trial enrolled 731 patients who were randomized in a 1-to-1 ratio to receive tirzepatide or placebo, with 364 patients receiving tirzepatide and 367 patients receiving placebo at 129 centers in 9 countries. The mean age of patients was 65.2 years. More than half were women, precisely 53.8%, and almost a third were non-white. The mean BMI was 38.3 kilogram per meter square, and almost half of the patients had type 2 diabetes, and 47 had a hospitalization or urgent care visit for worsening heart failure in the last year. The median duration of follow-up was 104 weeks, so about 2 years. The primary composite endpoint of cardiovascular death or worsening heart failure event occurred in 36 patients in the tirzepatide group and 56 patients in the placebo group, with a hazard ratio of 0.62. The mean increase of KCCQ-CSS was 19.5 points in the tirzepatide group and 12.7 points in the placebo group, with a mean difference of 6.9 points. And then, as a reminder for everyone, a higher score means that patients feel better. Both primary endpoints were statistically significant and favored tirzepatide. The key secondary endpoints included a mean increase in the 6-minute walk distance of 26 meters in the tirzepatide group versus 10.1 meters in the placebo group, and a mean decrease in body weight of negative 13.9% in the tirzepatide group versus only negative 2.2% in the placebo group, and a mean decrease in high-sensitivity CRP level of 38.8% in the tirzepatide group versus only 5.9% in the placebo group. Again, all these secondary endpoints were statistically significant in favor of tirzepatide. Regarding safety, 6.3% of patients in the tirzepatide group discontinued the medication due to non-fatal adverse effects, mostly gastrointestinal in nature, compared to 1.4% of patients in the placebo group.
Dr. Packer, the results of this trial are really exciting. I was at AHA and everyone was very excited whenever they came out. How do the results impact our treatment of our patients with HFpEF who are obese? And I want to hear a little bit of your thoughts about how important that dual action mechanism of tirzepatide is in this study.
Well, first, we were very excited to present these results at the American Heart Association. We actually had the opportunity to present 4 components of the trial and have them simultaneously published. One was the primary results paper, one was a mechanism paper, one was an expanded heart failure events paper, and the fourth was a paper describing the effects of tirzepatide on left ventricular mass and pericardial fat, which was assessed in a sub-study, dedicated sub-study, using cardiac magnetic resonance imaging. So we had a lot of data to show and explain, and altogether, you've described the top-line results beautifully. We had also a significant reduction in left ventricular mass. Originally, the patients showed left ventricular hypertrophy, and that diminished significantly in the tirzepatide group. Pericardial fat, which was greatly expanded before any treatment was given, reduced significantly in the tirzepatide group compared with the placebo group. Renal function improved. Troponins were reduced in tirzepatide compared with placebo. Almost every measure of heart failure severity, including the ones that you already described, which were pre-specified key secondary endpoints, but also many other measures of quality of life and the ability of heart failure patients to function were improved by tirzepatide compared with placebo. So this was a striking internal consistency of the results of the trial, and of course, external consistency with the prior results with semaglutide. So altogether, we were very excited. And of course, what made Summit special was this was the first outcomes trial in patients with obesity-related HFpEF, first trial in this disorder where the primary endpoint was cardiovascular death and worsening heart failure events.
I think it's probably what is an existential question surrounding HFpEF in general. But whenever we think about these trial results and we're talking about heart failure and we're also obviously talking about the reduction of obesity in our patients, how do we kind of suss out the improvement of symptoms due to weight loss versus some kind of mechanistic impact of tirzepatide on heart failure itself? I'd love to hear how you think about that a little bit, because I think, as Myrna and I are trainees, those are kind of the things that I'm starting to think about for sure.
Well, I can only share you my own personal opinion. There are people who would contend that this is all about weight loss. But I don't think that that would be the best way of looking at it. Remember, there are ways that people can lose weight where cardiovascular risk is increased. There's a famous large-scale trial with a drug called sirbutamine, which improved insulin resistance, reduced weight, had fantastic effects on lipids, but increased the risk of cardiovascular death and other non-fatal cardiovascular events. So it's not just about weight loss. It's about how weight loss is achieved. Here we have a drug that signals through the GLP-1 receptor, also signals through GIP, which is also an incretin. These receptors exist in the heart. They exist in adipose tissue. When these receptors are stimulated, adipose tissue shrinks. But it's not weight loss. It's the shrinkage of visceral fat that matters. And there is a disproportionate reduction in visceral fat depots. And these visceral fat depots are biologically extraordinarily active. They're very, very aggressive endocrine organs in patients with obesity and HFpEF. And when they shrink, they change their biology from a pro-inflammatory state to an anti-inflammatory state, from a state where growth is prioritized to a state of cytoprotection. And so it's the change in the biology of visceral adipocytes that really matters here. And we can't measure that by just putting the patient on a scale and measuring weight. Weight, is confounded. It includes muscle mass, it includes bone mass, and in heart failure, it can include fluid weight. So what we really, really care about is the shrinkage of visceral adipose tissue. And we can't measure that in the clinic. We can measure it by imaging, but that's not realistic. What we hope to do is be able to measure it with the use of biomarkers. There are biomarkers that track selectively with visceral fat. And we have a lot of biomarkers to measure in the Summit trial, which will be measured over the next 4 to 6 months. And we're very excited about seeing them because we think that there might be a biomarker that will help physicians track what visceral adipocytes are doing and how they're improving and how they're changing their biology from being pro-inflammatory to cytoprotective. I think there are going to be specific visceral adipocyte hormones that we can measure in the bloodstream that will give us a really, really good insight as to how these drugs are working and why people get better.
I do have a follow-up question about Jenna's earlier question on whether the improvement in symptoms are due to weight loss or mechanistic role for tirzepatide, as you were mentioning about, and decreasing visceral fat and pericardial fat. When you envision the role of tirzepatide in the treatment of our patients with HFpEF and obesity, do you view it more as a temporary medication that will get you some weight loss and some temporary improvement, or do you envision it as a long-term, almost lifelong GDMT medication?
I'm afraid that when people stop their incretin drugs, they gain weight back. So I think, as in the case of heart failure with a reduced ejection fraction, we have 4 foundational drugs and we prescribe them indefinitely, which means that there's no reason to stop. And there are data that if we stop them, people will get worse. I think the same thing applies to heart failure and a preserved ejection fraction. Our foundational drugs are evolving to a increasing degree of clarity. We have incretin-based drugs like tirzepatide, we have SGLT2 inhibitors, we have MRAs, we have neprilysin inhibitors. When we combine them, these patients will be taking these drugs for long periods of time in order to make them feel better, to improve cardiovascular status, to improve cardiomyocyte biology, and really have a major, major impact on heart failure worsening, heart failure hospitalizations, urgent care visits. The one thing that we haven't seen in any of the HFpEF trials is a reduction in cardiovascular death. We have seen them in HFrEF trials. We haven't seen them in HFpEF trials. And we are spending a lot of time thinking and looking at data to truly try to understand what cardiovascular death is in HFpEF and why it's different than in HFrEF. Remember, cardiovascular mortality in HFpEF is much lower than it is in HFrEF, and only half the patients with HFpEF actually are classified as having a cardiovascular death. So the concept of progression of disease here is really defined as worsening heart failure events rather than a impact on cardiovascular death.
Amazing. Thank you, Dr. Packer. We were thinking about another patient. So, for example, if we had a 70-year-old gentleman who had hypertension, diabetes, and chronic HFpEF, he was overweight with a BMI of 28, but an elevated waist to height ratio of 0.6. So, if this is a patient that's having NYHA class 2 symptoms and he's on daily furosemide and empagliflozin, he has good blood pressure control with valsartan. Do we have enough data to apply this trial to this patient? Or I believe he's somebody that would have been excluded. And I guess we're curious about others for whom results would not apply as well.
It depends on when you say it does not apply. Would he have been eligible for enrollment in Summit? And the answer is no. Do we have data on incretin drugs in this kind of patient? And the answer is no. Well, but this patient has the same pathophysiology as the patients who were enrolled in Summit. And as you know, these drugs are approved for the treatment of obesity in patients with a BMI of 27 or greater if they have specified cardiovascular comorbidities or risk factors. So would I treat this patient with a drug like tirzepatide? I would. Does this patient have an indication for tirzepatide? The answer is yes. Do I have data that the HFpEF in this patient would respond to treatment? The answer is no. But I've got some amazing data that would suggest that there is a benefit. And I'd love to do a trial of patients between 27 and 30 in BMI, tirzepatide versus placebo with HFpEF, and show that we can expand the reach of this drug to a wider patient population.
Great. I can't wait for that trial. But I wanted to ask, so apart from excluding patients with isolated central obesity whose BMI are less than 30, what are other limitations of Summit and what future investigations do you expect to follow?
One of the great advantages of Summit is that we did not have a natriuretic peptide criteria. And as you know, most HFpEF trials and the previous semaglutide trials had a natriuretic peptide criteria. Patients had to have meaningfully elevated natriuretic peptides. And in Summit, they didn't have to do that. And a lot of people had, either normal or modestly increased natriuretic peptides, and they responded really nicely to tirzepatide therapy. So that's a patient population that we studied that previous trials had not studied. Anytime you look at the results of a trial, and you are often wondering, gee, if we had only done this, if we had only done that, we have learned more. But one of the amazing things about Summit is that the results were so consistent that no matter how we looked at the data, no matter how we looked at subgroups, no matter how we looked at the time course of effects, we saw a level of consistency that we really don't see very commonly in heart failure trials. Remember one thing that's really so interesting about the Summit trial. It only enrolled 731 patients. 731 patients for a cardiovascular outcomes trial? Well, if you look at trials with SGLT2 inhibitors with HFpEF, they've enrolled 6,000 patients. Why did they enroll 6,000 patients? And we enrolled 731. Well, the reason is because they were looking for a small effect, and we were looking for a big effect. So MRAs, finerenone, 18% reduction in the primary endpoint. SGLT2 inhibitors, 21% reduction in the primary endpoint. In Summit, 38% reduction in the primary endpoint. Well, when you have a bigger effect size, you don't have to have a very, very large trial in order to discern an effect and achieve success on the primary endpoint. The reason we have gigantic trials is that the effect sizes are typically pretty small. And in Summit, based on the external data, we thought the effect size was going to be large, and it turned out to be large.
Thank you so much, Dr. Packer. Just as we're wrapping up, I guess I'd love to just hear what is something that we didn't ask you that you really loved about Summit, or just a point that you really want to drive home about this trial?
One of the really wonderful things about Summit was the relationship that we had with the sponsor. Sponsor was Eli Lilly and Company. And this steering committee of the Summit trial, played an incredibly proactive role. We designed the original study. We were so happy to propose an events trial to the sponsor. And when we saw the results of the semaglutide trials, we proposed a change in the primary endpoints. And so the steering committee was unbelievably active, and the sponsor was so receptive to our activism. We had to make sure that we made a compelling argument, but there are many trials where the steering committee plays a reasonably passive role. In this trial, the steering committee played an active role, and the sponsor was so willing and enthusiastic to listen to all of our recommendations and moved forward with them. That's an example of academic industry relations that we don't really see that often, but it really played out beautifully in the Summit trial.
Thank you for that. I think that's a really important point, especially as, again, a trainee about to transition to faculty. I think sometimes trainees don't get exposed to that kind of really positive academic industry relationship. And it's wonderful to hear. And obviously, it had a really significant impact with the trial results. Dr. Packer, it's been a joy hearing your insight on the Summit trial and how it impacts care for these patients. A little bird told me that maybe I should ask you one kind of interesting question, and you can ask us to cut it at the end. But I heard that your library is fairly legendary. And just to wrap this up, I would love to hear what your favorite book you have in your library is.
Oh my God. How did you hear that?
Like I said, it's legendary.
Yeah, it is. It is. Over the years, I've collected first editions, major works in human thought, medicine, philosophy, history, and these are works that change the way that people thought. Works by Kepler, Galileo, works by Withering, works by Vesalius. These transformed the way that people thought about the world in ways that were very durable. They have lasted for centuries. So these are not books from the 20th century. These are books that span from the 15th century to the 18th century. And every time I go into the library, I realize that I feel humble. I'm surrounded by books that have withstood the test of time much longer than I will. And I don't own the books. I'm a temporary custodian of them. My job is to take them from those who previously owned them, at least they thought so, and pass it on to the next owner. The books will survive much longer than the owners will. And that's the whole purpose of having a library like this. Every time I think the world is a little bit more stressful than it should be, either on a personal or a global level, I just walk into the library and I realize that if you are patient, then there is a truth that endures. What's really amazing for most of these seminal works is that the authors were terrified to publish them. Copernicus waited until the day of his death to publish his work because he feared peer review. William Harvey published his theory of the circulation and suffered for the next 40 years. Felt that he was really sorry that he had ever suggested the idea. When people think differently, the world doesn't have a red carpet for them. The world pushes back. And often those who originate these ideas are not happy about the fact that they've made a difference. But their whole goal is to write something that lasts for centuries. And the final say as to how the world thinks is represented by their writings. And that has great comfort with it.
Dr. Packer, the way you've described your library is truly magical. Like, I hope you offer tours to it. And I hope we maybe make a series just about your library and books and continue to learn from you about not just heart failure, but everything in the universe. Thank you so much for sharing that.
I'm delighted to have spent all of this time with you. We had a wonderful conversation. Thank you so much for the opportunity to tell this story.
Thank you, Dr. Packer. Thank you so much.
Hey everyone, do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you're shaking your head yes, then keep on listening, because Freed AI is a medical scribe on a mission to free clinicians everywhere. Freed AI listens, transcribes, and writes medical documentation for you. So just imagine leaving your office at the same time as your last patient. Now, wouldn't that be delightful? Freed AI is HIPAA compliant, secure, and takes less than 30 seconds to learn. Team, artificial intelligence cannot replace you, but it can do the administrative work that will allow you to spend more quality time with your patients and enhance your personal work-life harmony. So get back to doing what you love, helping your patients, and let Freed AI do the rest. Check out www.getfreed.ai to learn more.